Welcome to Healthcare Quality and Risk Matters. Wondering about patient safety, quality, and risk management, but aren't sure who to ask or we're afraid to ask? Well, you're in the right place. We've created a safe and judgment-free space to explore these critical topics to leave you informed and inspired to make a positive impact on healthcare. So, let's learn and grow together because healthcare matters.
Well, good afternoon, everybody. My name is Gary Bierce. I'm the CEO of ParitySoft Healthcare, and I am joined with my two esteemed colleagues, Rob Santamore, who is our Chief Operating Officer, and Dr. Timothy Brown, who leads our healthcare solutions practice. If you're listening right now, you have arrived to Healthcare Quality and Risk Matters. And our format is pretty simple and tries to be a little fun while we're at it, even though we're tackling some serious things. It goes like this. We're going to look at an incident of the month. After a little bit of Q&A on the incident of the month, we're going to transition to something we call Minute Matters, where each of us has 1 minute to answer questions from each other on the topic of the day. And then we'll go into a Q&A session. We'll take questions from the audience as well and try to make sure that before we finish our time together, we've answered all the important questions from you as well. The topic this week is proactive versus reactive risk management. Before we dive into the topic, Rob, I would like you to take a few minutes and just introduce yourself to the audience.
Hi, I'm Rob Santamore, Chief Operating Officer of ParitySoft Healthcare. And I grew up through the quality, compliance, and risk space. There's from the start in the transplant, there's world moving into behavioral health. And back into the ambulatory and acute care setting where I spend the majority of my time. There's in quality and risk consulting.
Timothy, how about yourself? Would you introduce yourself to everyone?
Absolutely. Good afternoon, good morning to everyone that's joining from around. I appreciate you for taking the time. I'm Dr. Timothy Brown. My background is really in healthcare across the spectrum of health, being a healthcare executive. I have about 15 years of experience working through different areas of the hospital, from telehealth to working in human resources and from that executive perspective. So I'm really excited to join our group here today and to be a part of this conversation.
And I'm the outlier. I have no healthcare experience whatsoever, but I do have 40 years of risk management experience. And actually, I'm one of a handful of people that pioneered enterprise-wide risk management in a manufacturing environment. I did that back in the 90s. So I've spent my whole life, my career in the risk management, and I'm excited about taking that experience and focusing it on the healthcare world and trying to make an impact on healthcare quality today. With that introduction, Rob, you are up. What is the incident of the month?
So I found a really interesting article. There's on a national news outlet about a hospital. There's a few months ago, that had made news because of some critical patient safety concerns associated with repeat and errors. There was 21 avoidable deaths. There was 178 injuries to their patients. Wow. Yeah, and the incidents have been trending up from year to year. There's within their organization. Incidents such as medication errors, surgeries on the wrong patients, hospital-acquired pressure injuries, and falls. And they identified a lot of the root causes around the pandemic concerns. And staffing.
Okay. Being a risk manager, let me just tell you guys, being a risk manager, I'm like, I don't see the connection directly.
At all.
That there's a lot more going on there than a pandemic and staffing issues.
Correct.
Without a doubt. So Rob, you being the quality guy here, I'm sorry, Timothy, if you had a question at the tip of your tongue.
I was going to jump in, but I'll wait.
So our theme today is proactive versus reactive risk management. What really screams out from the page for you, Rob, that this is clearly not proactive risk management?
So there's two main points that really stood out to me. and it is a trend, right? So we have an upward trend. So we're repeating the same things. And although Kappa management is not proactive risk management, right?
Mm-hmm.
But we're still
Can
not.
you for our audience tell everybody what a kappa means?
Yeah. So corrective action, preventative action. So there is a belief in healthcare that the PA part, the preventative action, when you're addressing a trend or incident, that is proactive risk management. But we can get into that because that's a whole nother topic as to what proactive versus reactive is. And Kappa management is not proactive. But the other thing that I see is that staffing is the same root cause being expressed over and over. And I'm seeing that across all healthcare right now. And when we have a consistent barrier that's in front of us, we have to find new and innovative ways to get around it. There's closing our gaps and doing really good risk assessments and finding new and innovative ways to function. There's when we have that barrier that is probably going to be there for the foreseeable future.
Absolutely. Absolutely. It's amazing when you said staffing. The first thing that came to mind is a number of healthcare systems that were doing travel nurses and bringing in, outsiders to kind of fill in those gaps across the board, Rob. So I know that's one of many solutions that many have done, but that can be a very expensive solution for healthcare systems as well across the board. So
Very.
thinking of cross-training your employees or providing additional options for extra pay. If you're willing to pay an outsider, as no knock on our travel nurses because they have done phenomenal for many healthcare systems that aren't allowed or able to hire. But if you are able to pay a particular travel nurse additional salary, which is sometimes almost triple what a nurse in-house is being paid,
Yep.
why not take that time to train your overall staff to do additional work and also reward them with that additional pay as well. So
I agree. In the implementation of technology, when we don't have FTEs, we need to replace those FTEs with technology to support our operating system. There's our operations, our quality, our compliance, our risk, and our patients. So seeing some hospitals implement virtual nursing. There's nurses are leaving bedside in droves. They don't want to be in the hospital anymore. They want to make their own schedule, and they know they can. In really good proactive risk assessment looks at those organizational trends, the trends within the entire healthcare sector. And they identify that gap is widening. So how are we going to close that before it impacts us, or how it impacts us worse? And we do that. By bringing in telehealth nurses on little iPads so they drive around like robots to do discharge planning and education. Right? We're closing those gaps with technology because they're not closing with writing the same thing in your Kappa planning today that you did yesterday. You're not doing. Really,
okay, so being the non-healthcare guy here. Dr. Brown.
We can go down that road.
Okay. It makes me nervous at the notion that if I'm hospitalized, that I don't have a minimum number of nurses available to take care of me when I've been admitted to the hospital. Isn't that a law that you must have to be a licensed hospital, a minimum number of...
Robert,
so
I see you eager to take it. Go ahead, Rob.
Yeah, that is an extraordinarily topic, and I guess controversial thing in the world right now of healthcare. So yes, there should be nursing and other care provider standard ratios, but not all states have a standard law that requires minimum staffing ratios.
Wow.
Yeah.
I know. And even ones that do have may not meet what is safe for true patient care, because statistically it is universally known that the larger your ratio, you go from 1 to 4 to 1 to 7, correct, you have a higher risk of falls, you have a higher risk pressure injuries, right? You're not getting turned as much. Falls are very often preceded by elimination needs, right? They have to get up and use the bathroom.
Correct.
And they've hit the call button 4 times, but your nurse has 4 other people that they have to see before they get to you. And we've not, as an organization, done anything proactive to make sure you have a resource as a patient to be able to use the bathroom when you need to. Your concern is founded. Your concern is very real, and it is very much sitting in front of every legislator in our country right now as a concern.
Wow.
Absolutely.
Well, why don't we then transition to Minute Matters?
Absolutely.
Guys, we can continue to talk about the incident, or we can just broadly talk about reactive versus proactive risk management in hospitals. But because you've been sitting quietly so much, Timothy, you get the first question.
Absolutely. I'll take the first question. You want me to give the first question or
Well,
proceed?
you have to ask the first question. You got to pick Rob or myself to be on the hot seat.
Oh, absolutely. So when we're looking at that perspective of proactive versus reactive risk management, and Gary, I'll give you this question. You'll start from the top as a CEO, and working in risk management as well. What would you kind of consider, or how would you really define proactive risk management?
Love that.
Well, I mean, from a risk management perspective, it means I know my risk. I know what I can anticipate are the incidents that I'm vulnerable to, and what they and the level of that is within my risk tolerance or appetite as I've defined it. That is a true proactive risk management program. From the incident that we just saw, I'm going to guess that hospital thinks of proactive being I'm addressing all of the audit findings in a proactive way.
Absolutely.
Which does nothing for getting ahead of the 8 ball, so to speak. It's just keeping ahead of the auditor the best I can, which it appears to be a bit of a down spiral.
Correct.
From that. So with that question, I'm going to turn the question back to Timothy.
Sure, absolutely.
You've worked in administration in hospitals all the way to the CEO level. How do they look at this topic and think of proactivity of risk management?
Can I plead the fifth? No, from that understanding, Gary, that's a very interesting question. And I'm going to give a very broad statement on it. It depends by health system, sometimes even by hospital within health system, of how they define quality.
So there's no standard out there. Everybody's kind of.
There is this unwritten standard, we'll say. Do our best to not kill anyone and not get sued. I think it is. Unfortunately, is what I've heard across the board. And I say that jokingly, but realistically, that really is the foundation when we come to risk and quality management. We bring our risk and quality team in once an issue has either been discovered from a surprise audit or we have an unfortunate issue within the healthcare system. It is not technically proactive when it comes to it. Rob actually mentioned this earlier, where we're trying to put the fires out that potentially come up. However, what are the ways that we can really prevent those fires? We haven't progressed to that overall knowledge, I believe, in many healthcare systems. And it's not all, but to many understanding the overall healthcare and risk and quality management, we have not progressed to those areas of what can we do to prevent these particular issues beyond trying to put the fires out as they have been.
Okay. Well, that means you get to ask a question again.
Oh, sure. Okay, Rob, I'll take it to you. You being the what we would consider our expert across the board for quality, how can healthcare systems start to build that plan for proactive healthcare or proactive risk management for their overall systems?
So I can play off of what you had alluded to earlier, and I do believe part of it starts with education. We are not prepared in healthcare. There's through our education or our available resources to handle risk proactively. There's to improve our quality proactively. We are spending majority of our time putting out fires. We talked in a previous podcast about the culture and the value that quality and risk bring to an organization, and it is not universally seen as a high value space within the hospital. It's a cost to the hospital, right? You have a cost of quality. And cost of quality has a very negative connotation to it, right? So I think that with our reference to implementing technology and implementing education, I think would have a massive impact on healthcare across the board. If we understood what true enterprise risk management and proactive risk management was, we would be much more apt to prevent 21 preventable deaths, 178 injuries that should not have happened. There are very few zero harm hospitals, but we can get darn close in most circumstances with some really good risk barriers up, right, where we're stopping risk before it gets there by identifying it way ahead of time.
Mm-hmm. Can I ask a follow-up question? I know I'm going out of turn, Gary. Please let me know.
No worries.
If I can, I'll come back. Okay. Well, to that question, what do you say to a healthcare system that says, well, we already train our employees on risk management. We seem to be doing great. However, they're experiencing something similar to the unfortunate deaths of 21 people. How do you get that information through to the leaders that you might not be providing the right education, or you need additional educations?
So I love that question. So 3 years ago, I worked with a hospital out west. And very engaged, phenomenal. There's buy-in to wanting things to be better. There's simply kept asking why, right? Our 5 whys, our 5 I's, what are they doing, and why do they believe in risk and quality, and what do they think their real impact is? There's eventually they ran out of answers. When it came to their understanding of risk, their understanding of the implementation of risk management. So I think that goes back, and I know it's not a great answer to your question, but it goes back to lack of education. In those roles, sitting in my master's for health administration, I had 1 class on risk.
Yeah.
And risk should be such a massive part of my education, right? I had 1 class on quality. I had 1 class on health information management. And these are the people running our hospitals. These are the people that are doing that. So I do think that the lack of knowledge and understanding is the biggest contributor in that space. Even the ones that really want the buy-in, they have the buy-in, they want to do the right thing. They just hit a wall because they don't have the foundation.
Absolutely.
Well, Rob, that means you get the question.
Okay, cool. So there's Gary, you are a pioneer in this space, and you and I have worked together for a couple of years now, and you've really helped me understand there's enterprise risk management at a much greater level than I did before we worked together. Going back to how healthcare people are educated in the space, what are some elements that we need to incorporate into our leadership training to be effective? There's making sure our leaders know how to do this.
That's good.
To be fair, enterprise risk management still is an emerging discipline. So although there are certain companies that have adopted it and have thoroughly embraced it and have been rewarded for doing so, there are different levels of what that looks like depending on the organization, for sure. But if you truly have an enterprise risk management program, what you're going to experience is that management is getting informed by risk information where they were not informed before, to make decisions that are going to make the organization more successful. And from a hospital's perspective, it means patient outcomes, right?
It does.
To have the best patient outcomes you could possibly have. If that's our goal, then our entire risk management program is about identifying the things and managing the things that could affect that. So if we go back to the hospital with the failures in Minnesota, that obviously is not their goal, and risk management is not driving in that direction, nor is it informing management accordingly. It almost seems like in hospitals, there is the worst case scenario, I'm reacting only to audit. And then there's an intermediate level where I'm reacting to incident reporting. And then there's another level where incident reporting is serious, and there's a true monitoring of completion of these CAPAs, as you mentioned earlier, but watching them to completion and making sure that they are part of policy and part of procedure. And then that next step would be, let's go ahead and try to see if we can identify what incidents may occur that may not have occurred yet. And let's see if they are
Yes.
probable, right? That would be a better image of what risk management would be doing in a hospital than simply looking at audits and reacting to what the regulators say we're supposed to react to.
Correct.
I love that answer.
Getting to that next level of
Yep.
quality and risk management, where I'm not just putting fires out, but I really am looking and watching out for areas that may be potential hazards to burn. So
Yeah.
I think as you incorporate that quality and risk management team into your conversations, whether it's your leadership, whether it's understanding your budget, whether it's just having them at the table, as I spoke to last month during our podcast, having that voice at the table to kind of identify those areas that the organization could bring potential risk to
Yeah.
the organization, it does take it to another level, and then you start to become that proactive healthcare system. I saw some amazing comments, actually a couple in the chat that I want to kind of highlight. From Dr. Christy Flake, who's one of our national directors. She says a strong quality program is a revenue protector rather than a revenue. So I
Yes.
think that is just like,
Hallelujah.
yeah,
Hallelujah.
someone
There's-
that fully understands it. That's an amazing comment across the board. Thank you, Dr. Flake.
Chrissy, that is my life. I have spent a majority of my career in quality, risk, and compliance, trying to prove to my leaders, and often successful, which I am happy to say, that my leaders were open-minded enough to hear this. There's quality and risk do protect your revenue, and sometimes even have the ability to generate revenue. Right? You have quality incentive.
Absolutely.
You have quality incentive programs where you can do risk-based contracts with your payers and be incentivized for high performing. There's organizations that you can't do if you don't have awesome quality and risk programs. Sorry, Gary, go ahead.
Risk is all about the negative side, the things that can hurt, but also is identifying those opportunities.
Yeah.
Correct.
And like we talked about last podcast, there's a really good culture of reporting. There's and although in itself reporting isn't always proactive risk, but the culture around continuous observation, there's potential risks that could be identified. Is absolutely revenue retaining, and it protects from lawsuits. It protects from. There's all of the other things that come with it, but mostly your patient outcomes. And that's where hospitals make money, is patient outcomes. They have other streams of revenue, of course, but the main one is, of course, your patient outcomes.
Absolutely.
It's interesting because you guys know I just recently had my hip replaced. And the method that they used is this newest method they call the anterior method, or minimally invasive. It's a full hip replacement, but they never had to cut any muscle. They never needed to do a lot of the things that the old method would require. I asked my surgeon, I was like, why doesn't every hospital or every orthopedic surgeon, why aren't they all doing this? And it was a risk-related answer. The first part was, one, the cost of the table that enables me to do this is very expensive. So the healthcare organization needs to be willing to invest in it. And then two, surgeons, and she says, this is how we are. We learn a way of doing something, and it's hard for us to break away and do a new way.
That is so true.
It's very hard. Now, I thought about that from a patient outcome perspective, because if you think about it, you guys know my recovery is 4 to 6 weeks. But the other methods can take 8 to 12 weeks to recover and have more complications. So if you're doing proactive risk management, and I'll throw this out to either one of you guys, wouldn't you want to consider a new way of doing surgeries in your hospital if you know it can improve patient outcomes?
I'm going to say yes, absolutely. There's a twofold answer to that as well. You've mentioned the perspective of surgeons that, number one, that either will learn a way and that's the way they want to stick to it. Then there's also those that really know that it could potentially help and also understand the risks behind it. I think in those conversations where you're doing your purchasing and hopefully having those conversations to bring in new equipment, you need to bring your quality and risk leader in that conversation as well to support the case for why it is important to potentially bring in this new overall equipment. I look at going back to our
Informed
incident of the month.
decisions. Yep.
It is one of those situations where are we willing to give up 21 lives or can we really save those lives with the additional cost of this overall equipment? So not to say that we're trying to weigh lives versus money or anything like that, but having that full perspective, having the full story. I think somebody actually mentioned that in the comment of having the why behind why you do things is very important to hopefully moving and progressing AI or any type of technology within the overall healthcare system. Rob,
I
I'll turn to you.
fully agree, Timothy. Adding in your risk compliance or quality people, and sometimes those words are interchangeable within whatever healthcare organization, how they define the roles. There's integrating them into change control. There's is a proactive step they can take, right? I want to make change. There's in the quality risk or compliance person's job in that space is to say what gaps are being created, what is needed to be successful, and how do we prevent. There's the preventable. There's from happening. There's so it's not we're just implementing. There's a new Da Vinci machine, right? There's what do we need to do that? What do we need to do from all perspectives?
Right.
There's our,
Absolutely.
so I think that is, and it also may partially address. I see somebody asked a question about how to embed proactive risk management into an organization culture.
Correct.
And I think that it is getting
Important
a seat at those
question.
tables.
Very,
It's getting that seat, and we talked about that a bit last time and getting the leadership to.
Yep.
There's open that door to say you are welcome in, but then also cascading that down to say, hey, operation leaders, unit leaders, you need to include these professionals into your change control, into your assessments. There's into your conversations, into your department's ops meetings. There's so the culture change really needs to come from the top, and then you need to have a strong collaborative relationship with quality risk and compliance.
Without the endorsement of the CEO, there is no way that you can make that culture change happen.
Agreed.
When we were developing ERM 20 some years ago in this manufacturing organization, in the beginning, I'm out talking to division presidents, and they're asking, what does the insurance department have to do with strategy? So they looked at me as not a risk manager or a strategic risk guy. I was the insurance guy. So there was a huge barrier to get over. Eventually, we got plugged into a specific division that turned their entire business around. They had never made any money for the company. They turned around a $15 million operating loss into a $15 million operating profit in 12 months.
Wow.
All by being proactive with the identification and the response to risk. All of a sudden, we were the rock stars, right? Everybody wanted us to help them with their division because of that great success story. So sometimes it begins by finding an area that could really use a turnaround and bring the proactive risk management to that area of the hospital, and then use that as the use case to spread it throughout the entire organization.
So true. So true.
I agree.
Yeah, amazing comments. I wanted to get to some of the comments in the audience that we have because we have quite a few comments and questions as well. So Rob, if you want to transition us to our next area, we'll jump into that comment section to kind of answer some of these questions.
Yeah.
So I'll read the first one. You actually read this one earlier, but I wanted to make sure that we did answer it. What steps can be taken to embed proactive risk management into the organizational culture? And that's from Zarina Jabbar. And we've answered this, I think, briefly, but I think one of the biggest things that we need to also hint on is the communication across different disciplines in the hospital. We have a tendency to work in silos.
We do.
And only bring out issues when they are too catastrophic for us to be able to take care of. And or if we are surprise audited and all of a sudden we find some situation that we just cannot handle, that's when we tend to come out of our silos. But I think we can do more work in collaboration with each other to ensure that everyone is on the same page, especially when it comes down to risk. That's patients, that's employees, that's across the board for anyone that's on the ground of either your healthcare system or hospital. So having open communication, incorporating your overall quality and risk leader into your monthly meetings, your one-on-ones, however you want to incorporate that for your teams. But just having them have a seat at the table so you know what the overall risks are for your organization. And I think someone actually mentioned this later on in comments, and we'll talk about it, but establishing what your why is and then posting it for all of your entire organization to
Yes.
see. That gets everyone on the same page.
Yep, I agree.
Any other questions?
Let's see, got great comment. I see one that says, in my experience, the ability to storyboard our why, validating with the data that is shared organization wide at a level that meets the role and its function is imperative. So
Agreed.
that's a amazing comment. That's Alicia Wallace Smith for that one. I see another one says, by establishing robust written procedures and integrating through all processes. So I like that. That's from Diane Lynn. Amazing comment as well. And she also put
That's a big component of ERM, integrating risk
absolutely.
management into business processes.
Absolutely. She also put risk management replaced prevention action program in the iOS newest standards. So
we love that comment. We are ISO certified here. We absolutely love ISO.
I see one more comment that says executive and senior leadership is a must. I believe that's in relation to what we were speaking about, having a seat at that table. And then the last one, it says, I can't wait to see the new iOS 7109 healthcare quality management more adopted. So great comment. That's also from Diane Lynn. So I think that's everything that I see in the chat. Rob, did I miss anything from your perspective?
No, not at all. The comments from there's Diane. There's I love them. There's the written procedures. There are 3 things that we could all implement, right? Like today that are proactive risk management, and that is education SOPs. There's and then implementing risk and starting your assessments, right? Correct. So we can start assessing. We can start educating. And we can start really defining our processes. So I fully agree that those are really important things as a first step to becoming a proactive organization that prevents 21 deaths that were otherwise avoidable.
Absolutely. This is my advice for 40 years in risk management. Mm-hmm. You got to get wins, right?
Yeah. Agreed.
Without a win, management's not going to get the attention to what you're trying to accomplish.
Absolutely.
Need to show them how this generally ties back to the performance of the hospital, key indicators that drive revenue. Make those connections, connect dots. Decision makers want to see that, and keep it at a high level. Don't get into the weeds.
Yeah,
agreed.
Have them understand it at a C-suite level, and then you retain in your own heart all the details that are behind it.
Absolutely. Keep it simple. When you come to your executive team, they only want the high-level details to make those decisions. And really, they only need the high-level details. You are the researcher. If you're the quality leader, you have all the data, but keep it to a level where they can easily understand what are those risks easily. What are we trying to accomplish? And really establish your overall motive to kind of move the organization forward. I would say
you get the last word.
Okay, sure thing. I was actually going to go into that, so that's perfect. I always say in an organization, when you do a surprise audit, there really should be no surprises. And oftentimes there are no surprises. It's just that either you have employees that don't feel that the culture is strong enough for them to be able to speak up, or there's no mean or process for them to be able to provide it. So we went through a major pandemic a few years ago. We're still coming out of on the end of it for healthcare. However, there's so many different things that we should have learned, but I don't think we have learned from a healthcare standpoint, and being proactive. How do we prepare for what's coming? How do we prepare for how to move forward in healthcare? And I think that is taking that more proactive approach and standing away from trying to put out every fire and really assessing the overall ground to land and finding a way for us to identify what areas are our biggest risks, what areas could potentially use additional resources beyond that. So it really comes from having that, like we said earlier, that system, whether it's an artificial intelligence system, whether it's a computer system, or having the processes in place for your organization to thrive and move forward. And it definitely starts with number one, having communication and having the right people at the table. So I'll turn it back over to you, Gary.
Okay, well, thank you everybody for joining us today with Healthcare Quality and Risk Matters. Next month, we're going to be tackling patient safety. Hopefully, we may have a guest to join us, someone we can put on the hot seat. We will be announcing that through LinkedIn throughout the month. Also, there are some materials that will be available for you once you click off. Please do that. Click on, and there's a white paper as well as a simple information slick that might be of interest to you. So once again, thank you for joining us with Healthcare Quality and Risk Matters, and we'll see you next month.
Thanks, everybody.
Thanks, Al.